Hi everyone, good afternoon. We will go through a few cases today in the next sort of 45 minutes on the main theme of cardiac masses, and if we've got time, go through some tamponade physiology, and apologies for missing the last couple of weeks. There was a talk that was recorded fairly recently of kind of going through all the cardiac masses lectures, and so I was thinking that if you wanted to look at that, it's on the website for you to follow, and I thought it might be useful for the guys who are doing the exams this time is maybe just to go through a few cases and just to work on the chat. I'll present a case or two. We've got MRR Echo Fellow who'll present a great case, and we'll go from there. Why don't we start off with a straightforward-ish one. Lewis, you happy to kick things off?
Yep. Looks like it's going to be me a fair bit.
Just you. We've got Emma and Louise here as well, and Sam. So, okay, so story is of only 61, so that's 40, 50. So 60-year-old man, short of breath, with history of with a cardiac history. So we'll ask you, obviously you're looking at an echo for that. Can you see it okay, Lewis?
Yeah, I can. Sorry, you just cut out there. I didn't hear.
Oh, excuse me. It's a 60-year-old man who's short of breath with a cardiac history.
Okay, so this is a parasternal long that is somewhat off axis and with an increased depth. The abnormal findings appear to be reduced LV ejection fraction, probably moderately impaired. The RV outflow tract is not well imaged, so it's a bit hard to comment on. Left atrial size looks like it's probably normal, and there's no clear pericardial effusion or clear pleural effusion demonstrated in this study. The posterior wall looks like it's moving fairly well, but the interventricular septum looks hypokinetic at least. That's probably all I can say, other than the cavity size is maybe a little bit enlarged.
And so how do you think this might relate to the history of the shortness of breath?
Yeah, so
it's related.
So this would be consistent with a heart failure with reduced ejection fraction presentation and subsequent pulmonary edema.
Do you think it's unusual we got a normal sized left atrium with that?
Yeah, it does. Well, without any other history. Oh no, you said he's got a cardiac history. Yeah. Then, yeah, that doesn't quite make sense, particularly if he does have an increased cavity size. A dilated cardiomyopathy would be associated with increased filling pressures. So I'd wonder whether there's an acute process going on here.
Okay, we'll just go through. I'll give you two pictures. So these two are the short axis views.
Yeah. So this confirms that there's a reduced ejection fraction, moderate to severely impaired. There isn't very good imaging of the anterolateral walls, but it also is consistent with the previously imaged findings, which is the anteroseptal hypokinesis, and also the infraseptal wall doesn't seem to be moving very well. So septal hypokinesis with some preservation of the apex.
You think this is preservation of the apex?
A bit hard, sorry, it's a bit hard to say.
Say again?
It's a bit hard to see.
Yeah. All right. We'll move on to the apical view.
Yeah, no, so the apex doesn't look like it's moving very much. So that's so this would be consistent with an LAD territory.
Fantastic. Excellent. And when you say not moving very much, could you be specific for me?
I think so. There's akinesis of the apical segments. That's clearly demonstrated there.
So what further imaging would you like to see?
So, so first thing I'd want to look at is some orthogonal views. So apical 4 chamber, apical 3, just to confirm those regionals that we've seen.
I don't have great ones of those. Sorry.
I'll probably zoom the apex to make sure that there's no LV thrombus. Okay. So I'm outside, so there's a lot of glare on my screen. Doesn't look like there's an LV thrombus there.
And if you were concerned?
Always concerned when there's a regional involving the apex.
Excellent.
And I don't find color Doppler tends to help very much, but I do often put it on. Yeah. And I think if the clinical suspicion is enough, a DEFINITY scan.
Good man. Can you critically analyze this image for me?
Yeah.
Is there anything that could have been done better?
So the Doppler scale's quite high.
Good man.
So if you, yeah, so you're probably going to get some what's it called? Bleeding artifact of the color. So it won't necessarily pick up a low flow, low sort of stasis.
Yeah, very, very good. Yeah, nice. So we should be so closer to 40, I would have thought.
Yeah.
Anything else?
Well, so it's a static view. You'd want to make sure that you were panning through the apex rather than just having a look at one position of the apex. And you would also want to make sure that you had probably increased the depth a little bit just to look for thrombus that's mural rather than just apical.
And the only last thing I was going to add in, I was just showing here, is the focus position. I think if we're looking for thrombus, the focus position should be at the apex rather than at sort of mid-ventricle level. And I probably could have imaged that a little bit better.
Yeah, thank you. All
right, so you wanted to see it with DEFINITY. Which is the best one? Probably that one's pretty good.
All right, so there is, so this LV contrast study, it's probably apical 4 chamber, because it's the one that's first, demonstrates an area of no contrast at the apex, consistent with an LV thrombus in this clinical context.
Excellent. Do you think it explains the shortness of breath?
No, not really.
Yeah, cool. Yeah. Nice. Excellent job. Yeah, I mean, you're hitting all the buzzwords there. You're telling me about the walls before I asked, which I really liked. My only comment would be trying to link it in early with the clinical picture. You know, the exam's going to be focused on that, trying to integrate echo with clinical findings. So always try and bring everything back to the clinical findings without the examiner having to prompt you. We're going to, there'll be basically 6 to 8 questions. Every candidate will have to get through the same number of questions. So if the examiner speeds you up, don't be put off. It doesn't mean you're wrong. It's just we've got to get everyone through the same number of questions. And we grade people whether it's a fail, borderline pass, passed well, excellent pass, I think it is. And you can have a certain number of borderline passes, but you can't have all of them. Obviously, if you've got a fail in there, I think we say that you can't have a fail in any of them, but you should be able to have, you know, but you can get away with borderline passes. And so it's all dependent on prompts. And so as long as you're, you know, again, just trying to tie it in back with the clinical picture, understanding where they're going to go to next. And just like you said, if you see apical akinesis, you've got to say that you'd be wanting to go and look for thrombus. And you do that with, just like you said, off-axis imaging, color Doppler, which isn't excellent, and other views and definity contrast, which is great. Excellent. The only other thing was talking about the regional walls. You said that the apex, it doesn't move very well. It's probably a personal thing rather than anything else. It's either it moves well or it doesn't, and it doesn't move very well. It's going to be akinetic, hypokinetic, or dyskinetic.
I will try to incorporate more terminology into my phrasing.
It's probably a personal thing. It's
I hated myself when I heard myself say it.
Excellent. No, clear pass. Awesome. Jamal, do you want to have a crack at one?
Yeah, sure. I just asked.
This is a cracker.
Oh God. Okay.
Right. We were referred this lady who came into ICU. She was short of breath. She had an abdominal scan for something I can't remember. A query there was an inferior vena cava mass, but she was short of breath and got intubated. And so we were looking at refer this lady for a right heart assessment. Let's start with first view for a right heart assessment. She's not very old. She was.
I'm just going to step outside. You're frozen. But so she was a 20-year-old with dyspnea. Yep.
Yeah, fantastic. So with dyspnea, some abdo discomfort, and a CT scan that suggested there may be a thrombus in the IVC.
That's very interesting.
That's query study, basically.
Okay, so I'm outside now. So let's have a look. So this looks like a parasternal long axis view. So what I'm seeing here is primarily the left ventricular structures coming through a very limited frame rate. The aortic valve looks thin and seems to be moving well. It's very choppy, but I would say that the left ventricular function is normal. I would want to see that in other views. The left atrial size, at least at appearance, would probably be within normal range. The only pertinent findings, to my mind, so it's not large enough that I can see the pericardium or the structures deep to that, but the left ventricular wall thickness, at least on this view, looks like it could be hypertrophied, and the nature and movement of the mitral valve looks abnormal to the point that there appears to be contact with the anterior mitral valve leaflet and the interventricular septum. I'd have to slow it and go through cine, but
yeah, nice. And I may be off axis a little bit. As you can see that we've got the papillary muscle that's coming in that tells me that I'm probably not being absolutely ideal in the imaging. So I'm probably off axis a little bit, which can make it seem like obviously there's worse hypertrophy. But as you said, you want to see other views. Do you think the right heart looks normal?
Well, again, so taking into the assessment that you are off axis, I'd be less inclined to make a comment, but it does look like it could be enlarged in this view.
Good, cool. So we're going to move now to the RV inflow view.
Oh, goodness.
Well, I mean, if this is the RV inflow view, then it's hard for me to. I'm not really familiar with the structures we're seeing here, but there's definitely a valvular structure, so that limits it to probably the tricuspid valve in this view.
Yeah, absolutely, yeah.
And then, but it's with the color flow, I can't really orientate myself, but there does appear to be a mass that we are staring at in what is probably the right atrium.
Excellent. And can you try and describe that mass to me?
Well, it's very large. I mean, if you look at the calipers on the side, it's going to be probably at least 5 centimeters in diameter. It's basically including the portion of the right atrium that we can see. It's homogeneous and it seems to be quite fixed, in its motion. So
excellent. So you said large, fixed. homogeneous, I think, is a great term. So I was going to say smooth walled as well. I think that makes a difference.
Yeah.
Yeah, excellent. Say it.
Not moving.
And not moving, yeah. Well, the fixed, I think you said it was fixed. Yeah, no. So
So again,
fixed,
yep.
smooth, homogeneous mass in the right atrium. Excellent. This is it's not a great view again, but this is the short axis at the aortic valve level.
Yeah. So I mean, that as you say, the central structure is the aortic valve in short axis, and that's kind of RV inflow outflow around it, which kind of reinforces the views that we had previously of this this exceptionally large structure, which is clearer now in the right atrium. I guess the thing about this and the image that you have is that because there is a potential for this mass to be occluding basically the right atrial inflow, this orientation does allow you to line up Doppler across it to see if there's functional tricuspid stenosis. And so it gives you a good Doppler angle, I guess, for interrogation.
Reasonable answer, yeah. I'll try and show you a couple of.
There we go. Yeah. So this is, I mean, this is not the most stable apical view here, transthoracic, but it definitely it significantly delineates the point of interest. So we are focused on the right atrium from the last two views, and it's quite clear now that she has a very large mass in the right atrium. The left ventricular structures are visible, but there is a bit of dropout with probe movement. But this kind of confirms normal appearing left ventricular size and function. You can see the intraatrial septum, and you can see this enormous mass in the right atrium. Wouldn't necessarily want to comment on right ventricular size or function on this one in particular, but definitely the most pertinent finding is this, again, kind of oval, homogeneous, enormous mass, which basically takes up the entire right atrium. There's a number of differentials, and obviously many of them are histological diagnosis, not echo diagnosis. You know, these include things like tumor and thrombus. But given this patient's age and one presumes otherwise status, the location and size and appearance would be suspicious for a myxoma. But this patient has to be relieved of this mass one way or another.
Very nice indeed, very nice. So if it had to be a tumor, if it was a tumor and other than a myxoma, have you got another differential? And what other views?
So what other views or what other tumors?
What other tumor could it be? What other kind of mass could it be? And what kind of view would you like to see to help try and differentiate between a myxoma and maybe another kind of tumor? And this is for the prize thing, because you did this question.
Well, I guess I think secondary tumors are probably the most common. Rhabdos are also common, but in younger patient populations. The other things it could be tumor thrombus in relation to a renal cell cancer. So you might want to drop down and interrogate the length of the hepatic IVC and see if there is tumor thrombus extending from there. But if you're concerned that it was a myxoma, which is possible and likely, then you probably want more focused views of the intraatrial septum to see if there is a pedunculated connection between the septum and the mass.
Yeah, no, excellent. So what's the most common chamber to hold myxomas?
What's the left? I thought it was the left atrium.
Yeah, it is. So one of the things we can do is I guess one of the views that we'd really be after be the subcostal view with the looking at the IVC to see if it comes from somewhere, because if it doesn't, then it's going to be more likely to, or potentially to be an atrial myxoma, which I agree it could look like. But atrial myxomas move. I'm going to show an example just now because it's, of course, the myxoma should be in the differential, but as you said right at the beginning, it's fixed. And that helps point it towards the idea that actually this is probably coming from the IVC. Myxomas are going to swing around. Mm-hmm. And if something comes up from the IVC, as you said, it's going to be a thrombus or it's going to be a tumor. Mm-hmm. And this is one of the ones that is fairly, looks like nephroma, a renal cell cancer. And so that's why we went on and tried to do some renal ultrasound. I don't think they were fantastic, but we started to get the idea that maybe on the left kidney, and I'm amazing at doing general ultrasound, but you can start to get the idea that maybe this sort of left kidney area, there's something that is not right here.
It looks a bit disorganized.
Absolutely. And this is a large left kidney tumor, a nephroma that was then going up the IVC into the right atrium, which is why it's fixed.
Yeah.
So other imaging, the answer maybe to the other imaging would have been, we want to do ultrasound of the kidneys and we want subcostal views and interrogating particularly the IVC.
There were some ascites there.
Yes, I think there was. Maybe also been a pleural effusion in there. Yeah, nice. Some free fluid sitting just there, well spotted. In Morrison's pouch.
Is that but that's the right kidney there, is it?
Yeah, right.
Yeah, because that.
So that doesn't.
looks,
that's not the one that was causing the trouble. I think it's on the left side.
Well, that looks far more organized. That looks far more organized than the left kidney. Yes.
Absolutely. So just, I won't test anyone on the next one. Actually, no, I will. Sam, are you want to have a go at the next one?
I don't think I'll be too good. I don't think I can speak like the other guys.
You're all right. Have a go at it. It's going to be great. It's a good one. It's more about, I guess, more about using the terminology to describe it is what I guess I'll particularly be hoping to try to go through if you don't mind, just to try and explain. Do you do a lot of transesophageal echo yet?
Oh, I'm just learning, self-learning. I do my own transthoracic echoes. I don't do any toes, not in TARI, so we don't do that, obviously.
How about we just go through this one together, because just from the one that we had last time, with that right atrial mass that was fixed and stuck there, it was, as Jamal very clearly described it, it was an enormous, smooth, homogeneous, fixed mass in the right atrium. And that leads itself to think that it might be something coming from the IVC potentially. You know, it's not 100%, but it's just the best that we've got. As opposed to this one, which is also in Jamal's, it was in his differential, which he talked about a myxoma, which is what this. Could you just try and describe this mass for me from an echo point of view? And I'll help you out because we're doing transesophageal echo here. This is at 0 degrees and it's an attempt at what's known as a mid-esophageal 4-chamber view. I'm probably a little bit high because you can see the aortic valve, but we've got the left atrium here. Here's the right atrium. Here's the right ventricle, and here's the left ventricle. So this is an example of a myxoma, and what would be great if you don't mind having a go is just trying to describe it for me in echo terms.
So it looks very circumscribed, regular, and it's just probably a pedunculated tumor that is arising from the upper wall of the left atrium.
Nice. That's good. So smooth, pedunculated, homogeneous, heterogeneous?
It looks homogeneous.
Fantastic, fantastic. And so the differentials for this, you know, top of the list with those things you just described, you know, large left atrium placed, pedunculated, homogeneous. It's mobile, I think, is the other important one to say. Those are all the classic ones that we'd say would be associated with a myxoma. Other differentials would include, what do you think, Louise?
A tumor or a thrombus? Or?
Yeah, nice. It could be another tumor. And which is more common?
Lipoma.
Metastatic, about 40 times as common as primary. So it could be a metastatic disease. And I think for any mass in there, you've always got to include thrombus or infection. And that's, you know, you've got to take in history into the assessment. Very nice. So with these guys, again, you're looking for, as you were saying, you're looking for that, the stalk. It classically comes off the interatrial septum. And with this lady who had some palpitations and a transient loss of consciousness, you have to watch that it's blocking anything up, and it's not blocking the inflow to the left ventricle. And so that's why we're looking with color Doppler around at this incredible looking mass. So making sure we've got reasonable flow into the left ventricle.
An interesting case.
Oh, sorry, you just cut out. You're on mute.
Oh, sorry. Oh, sorry, Sam, are you talking to me?
Yeah. Sorry, someone just
Yes.
saying something. An interesting case.
Yeah, sorry, I just dropped out for a second.
You okay?
Hello?
Oh, yeah, we can hear you. There we go.
Sorry, yeah, sorry. Did you have a question, or I was off mute for a second, but I remuted myself?
Yeah, someone said they had an interesting case. I thought it was you.
Oh no, one of my colleagues was talking to me. Sorry, that was before I realized I was off mute. Sorry.
Good. Always keen to hear about interesting cases. I don't really have too much more to say about that one, probably. Emma's got a pretty good case. Do you want to go through your case? Might just hand the microphone over to Emma. I'll tell you what, when I move out your.
Hi guys, I'm Emma. I'm the current Echo Fellow. So I'm going to go through a case that we had of a 62-year-old chap who was referred to our ICU with a history of confusion, and he arrived in shock with a blood pressure of 130 on 40, and he was promptly started on noradrenaline. We did a transthoracic echo on him, which we promptly moved to a transesophageal, and he was growing MSSA in his blood. So we were very worried about potential for infective endocarditis, and that was the indication for the.
I think it is the WTR58.
Oh yeah, got it. So we might just start with a few. So Prof and I did this together, and we might just start with the. Yeah, we'll go straight to the transesophageal actually, and just get you to. So I don't know, perhaps Lewis, do you want to describe, I guess, what you see? And so 62-year-old chap shocked on noradrenaline, blood pressure 130 on 40, and MSSA growing in blood. And the indication is to look for evidence of infective endocarditis.
Yep. So straight away with a pathogenic organism like that, I would be worried about significant valvular destruction and acute severe AR with that pulse pressure. So that's probably where I would look first. I can't.
So I was just showing you the 2D there, Lewis, so that where it's low, and it's the deep transgastric view.
Oh, okay. Yep.
And then this is with colour through that. Do you want to perhaps make some comment on the colour Doppler there?
So that so if it's deep transgastric, then that looks like it's probably a regurgitant jet arising from the aortic valve, which would be consistent with the clinical picture. And I can't see the scale. Yep. So the scale's 64 or so. So that's a significant jet that's terminating in the apex of the left ventricle. So that's a significant regurgitant jet.
Yep. So based on just these two initial views, are you thinking what grade of aortic regurgitation are you thinking?
Severe.
Nice. And I'm just going to take you straight to the short axis actually of the aorta. Do you want to comment on the aortic valve, the appearance of it?
Yeah. So the aortic valve looks. It's hard to tell if this is a tri-leaflet structure. It doesn't look normal, and there is thickening of the leaflet tips, and yep, thanks. And frozen open, it looks like it's probably a bicuspid valve, having the sort of classic football appearance. In which case, there's the non-coronary cusp appears to be intact, and there's fusion of the left and right, with thickening of the leaflet tips, and thickening of, I guess, the raphe fusion area.
Which raphe a joint?
So that's the non-coronary cusp there. So it's a left and right.
What's the most common type of bicuspid valve?
Oh, I knew you were going to ask me that.
You've got 50-50 chance now.
There's one that's more common than the others. I think it's left and right fusion, but I will have to double check that.
We can double check with the people in the room. I think that's right. What?
I thought it was the non. I thought it was the non and the right. I could be wrong as well.
Oh, we'll have to.
It's on one of my talks.
It is. I know. I've been taught that before.
Well, I think that's if you're saying that he's got a raphe between his left and his right, that's like a Sievers 1. So it's a Sievers 1 classification where he has one raphe. And then within that, I think that subcategory, the most common of that is the left-right fusion, which I think is about 70%, about 70% from that original article.
Well, brilliant. Thank you.
Thanks, Jamal.
Sievers.
Sorry, Sievers classification, which kind of that relates to the number of raphe that they have. Because sometimes we see truly bicuspid valves that have no raphe, but as you pointed out, this one seems to have a raphe or a fusion between what would be classically his left and right, so that makes him Sievers 1. So how old was this gentleman?
62.
Okay, and did he have any clinical history which was concerning for endocarditis, like drug use, or was he just an otherwise normal 62-year-old?
No drug use. I don't want to I didn't want to give the game away with that vignette, but he was actually known to have a bicuspid aortic valve with the AR awaiting a Bentals. So he was already
because I guess that's the other thing, isn't it, that the bicuspid valve is a known risk factor for infective endocarditis. So if he's known to have a bicuspid.
Yeah. All right, we might move on just maybe to describe the color there.
Yeah, back to me.
Yes, thanks.
Yeah, so there is regurgitation evident at the orifice, and it also looks like the regurgitant jet extends into the non-coronary cusp, and I'd like to see that in orthogonal view. So look for leaflet perforation, but there's definitely a regurgitation occurring at the orifice.
Yeah. Do you think you'd be able to do any sort of semi-quantitative measurements on that jet in terms of the jet height compared to the jet area compared to the LVOT area, and what might be some caveats if you did do that with this type of jet?
So I think that's probably better assessed in mid-esophageal 5-chamber or 3-chamber to get a better idea of the jet area, because not able to truly appreciate what's regurgitant there and what's turbulent flow.
Yeah, nice, because it's hard to know what level you're at, because to do it you need to be a centimetre below the vena contracta. So that's one thing, is that you'd need to probably have biplane to know that you were below the vena contracta, measuring that jet area, and also the eccentricity as well. Like if a jet would make it hard, so you might underestimate it because it appears to be eccentric. It's probably not the best thing.
No, thanks. You've answered that much better than I did.
I just had a bit of time to think about it.
I thought your answer was pretty good too, Liz.
And then we just slowly sort of rotated the omniplane, just because the thing that we were looking for was a vegetation. Perhaps you want to comment on this, Lewis, and see if there's anything that catches your eye at this stage.
Yeah, so mid-esophageal 3-chamber, zoomed in on the aortic valve, a little bit off axis, demonstrating aortic valve leaflet tips that are restricted at the tips, but with relatively normal mobility of the remainder of the valve leaflets. There's thickening at the tips as previously described. There's an independently mobile lesion that appears in the LVOT just briefly there. Yep. that would be concerning for endocarditis. I can't see any 2D evidence of a leaflet perforation. The aortomitral curtain appears thin with no clear evidence of an abscess. But I would want to have a bit of a zoom look in that. And it does look like there's some aortic, increased aortic size, maybe aortic dilatation is still in the ascending aorta.
So for his size, the sinus and the sinusoidal junction were normal, but his aorta is dilated at 45 millimeters. I haven't actually captured it on this study. What do you think about the severity of that jet? And what else might you be looking for here, Lewis? Other things to confirm what you're suspecting of severe AR. There's another thing that Sam reminded me of today, that you can either look for in M mode or you can look with color.
So diastolic fluttering of the mitral valve is another feature that I would look for. And if it's acute severe AR, you'd expect a normal LV cavity size. That AR looks severe. It's hitting the back wall of the left ventricle and extending down into the apex. The jet area is somewhat eccentric, but appears to cover more than 60% of the LVOT. And once again, I'd be concerned for leaflet perforation there, because it appears that there's flow in the area of the leaflet as well as the commissure. Did that answer the question? Or what else would I look for?
We'll keep going. So you've talked about the color jet filling the LVOT.
Yep.
You talked about the fluttering of the anterior mitral valve leaflet. Keep going. There are a few other things that we could be looking for. Maybe not on this image, but in other images. What else would you want to see to assess the severity?
Yep. So I'd look at the vena contracta. Once again, although that's
what value is severe for the vena contracta?
Sorry, say it again.
What value would be severe for the vena contracta?
I think it's
The clue there.
I think it's 6.
Yes, 7. Yeah, 6 or 7 millimeters. Yeah, I'll take that.
All right. And what else would I be looking for in acute? I'd probably think about imaging the aortic valve in 3D if I had that modality in the TOE.
But stick with conventional stuff first of all.
Right.
There are a few other things that we can look for. Oh, very nice.
This doesn't add very much, but it looks.
I was going to say the same thing.
Yeah.
We're talking about assessing severity, but they're very pretty pictures.
Yep. So you can calculate the effective regurgitant orifice area by looking at the
easy ones. First of all, using Doppler. So one's using continuous wave Doppler, and one is using pulsed wave Doppler.
So the easy ones are looking for flow reversal in the descending aorta.
Yep, and the one with continuous wave Doppler.
Pressure half time.
Yeah, that's tricky with the eccentric.
Yep.
I find that's difficult with toe, but agreed, and we'll show you maybe a picture of that. What about its assessment of the mitral valve?
So I think I mentioned the diastolic fluttering in the mitral valve.
Oh, no, diastolic. What?
And early closure.
Yes, it's diastolic MR.
Oh yeah, yep.
Fantastic. Good. So diastolic MR is a sign of maybe associated with acute severe regurgitation, and then there's this one. Just tell us what this picture shows.
So that is the descending aorta. That's the so there's hollow diastolic flow.
Very nice. And with the hollow diastolic flow, there's another little part that we look for, which we talk about with the diastolic MR. a diastolic flow reversal in the descending aorta?
So it has to be above a certain, it has to be above a certain value at the end of diastole, which I think is 0.2.
Good man.
I would have to see.
Excellent. Well done.
Yep.
I might just show this one picture as well. So talking about the pressure halftime, the reason why I go on about the things like the diastolic MR and the diastolic flow reversal, hollow diastolic flow reversals, it's really hard to balls those up, right? It's very difficult to make them look severe when they're not. Well, as opposed to in toe, one of the problems with toe is that you're not quite as you can't be quite as creative with your Doppler angles as you can with transthoracic, which is why in these kind of cases it's really nice to do a bit of both. And that's what Emma was showing you, the suprasternal view just there for the hollow diastolic flow reversal. Because if we're in our deep gastric view here with the color Doppler going through that aortic valve, and that with the full anti-flexion going on, this is kind of the best view that we're going to get for looking for that continuous wave through the aortic valve. I wouldn't be confident making any kind of measurement on that, right? We could put that thing wherever we wanted. So yeah, it's tricky sometimes using the pressure halftime and you don't have a beautiful trace, I guess would be the caveat. Last thing, how do you tell the difference between acute versus chronic AR?
Clinical history and signs of LV volume loading, which would be normal versus dilation of the LV.
And I would say the last one with acute MR, with acute severe aortic regurgitation, you're more likely to get rapid equalization of pressures. So you get that cutoff sign, the V sign in the continuous wave Doppler through the valve.
Yeah.
So yeah, here we go. They've got the left ventricle 71 millimeters.
Okay.
Might just do one more if that's okay. Great case. Thank you very, very much, Amar.
Yeah, no, that was good.
Louise, do you want to do the last case?
Oh, yeah.
So this one is I've forgotten why we were doing this one. Hang on. That's right. It was a study for query infective endocarditis with an MSSA bacteremia. And just in the meaning of time, I'm going to take us to our area of concern. So we're getting towards the end of the study. Go from here. So getting towards the end of the study, all the valves and everything looks okay. And then I take this image. And we're concerned about infective endocarditis. And I'd just like to focus your eyes on the aortic root.
Okay, and this...
What is that?
What is it? It appears to be a mobile mass.
Nice.
That is independently mobile, that looks like it's heterogeneous, and it is about, I don't know, 1.5 centimeters long and about 0.5 centimeter wide. It does have irregular edges.
What would be differential diagnosis?
So thrombus, it could be endocarditis, but basically that's infected thrombus as well.
Anything else?
No, I'm obviously not thinking of what you're thinking.
Keep going. So again, with everything, I think with any mass in the heart, we'd have to have that differential. Have that standard differential.
Think about
tumor, okay.
So which could be metastatic or it could be primary.
Yeah, metastatic being more common. Cool. Give me other things.
He's not had any surgery on his
Nice. So it could be
aortic root. It could be a
iatrogenic,
stitch.
yeah. So it could be us with either
stitch.
lines, stitches, devices we're putting in. Nice.
It could be a flap associated with dissection.
Yeah, cool. We could have a dissection flap in there, pathology.
But
How
it
about
doesn't look-
non-pathological?
Non-pathological.
Can you please show a lesion? So we're just focusing in here in the aortic root, this mobile mass that's sitting.
Lamble's excrescences.
Fantastic. We're just focusing on this little bit in here, Sam. Okay.
Does I expect that to be attached to the end of the?
Yeah, exactly. You'd expect Lamble's
it to be
excrescences to be
attached
attached there. Nice.
But I can't. We would have to get another angle to see if it's actually attached to the end of the cusp.
Yeah, cool. And then the other things would be normal variants. So as well as the Lamble's excrescences, we could also be thinking of things such as artifacts. Okay. So don't forget about the artifacts. So then the question is going to be, how do you tell an artifact from a real structure? What would you want to do? So if I looked at this and was
I'd want
concerned,
to look at it in multiple angles.
Cool.
So probably you're pretty close to your right depth. I'd move the focus down and to approximate that, and I would decrease the depth as much as possible. I would try moving the probe so that it's coming from a different angle, because if you didn't have, you'd need to see it in more than one angle, and if it disappears after and it only appears in one angle, it would be more likely to be artifact, particularly if it doesn't look like anything else.
Very good. Exactly right. And just in terms
of, you put, you would also put, well, if we had, you'd put color Doppler across it, because color Doppler would kind of just run over it.
Yep, beautiful. So run over it as it does here, so we can't see that mass, so it's coming over it there. We try and change the depth to see if we can still see it, and I think it is much less evident here, and we've changed the depth. Look at, as you said, in different angles, and I can't elucidate it again in different angles. And then my final thing is can you explain it by physics of echo? Where's the first one gone? And I think you can explain it with this one, because I think it moves in time with this part of the image. And so I think this is where the echoes come down here, it's hit that anterior part of the aortic root, it's come back, it's hit that free wall of the left atrium, it's come back, it's hit that, and then it's been picked up by the ultrasound wave. So it's almost look exactly
reverberation though.
I agree, but the distance between that thing as it moves is the same as the distance between those two. And so I think you can describe it as being an artifact that moves together. I think the top and the bottom are coming together around that fulcrum point right in the middle there. So they come together the same. And that was one of the first things I caught with my eye to suggest that maybe this is an artifact. And then we go through that systematic approach.
The other thing is that this is always a tricky part, because you often pick up artifacts around the aortic valve from this view. And I agree with you, Sam, because the clue is that, in fact, it's moving in tandem. It's not independent motion. It's moving in tandem with the other, whether it's that surface or another one, it's moving in tandem with the aorta.
Nice. Yeah. Awesome. So I think we've hopefully gone through most kinds of masses we're going to see there. We probably haven't gone through a lot of the normal variants. So the normal variants would be the Lamble's excrescences, as Louise discussed, eustachian ridges, Chiari complexes in the right atrium. There'd be another classic that we'd bring in. And then obviously thrombus is a very common one, particularly in areas of low flow. So don't forget the left atrial appendage and the apex of the LV if there's any akinesis there, particularly regional wall motion abnormalities. And then if you're worried about thrombus, if you're worried about infective endocarditis, it's got to be a history of having some bug that may be suggested with that. And it's often associated on the downflow part of the valve. If one valve is affected, you've got about a 30% chance another valve is affected. And then finally, if you think it's tumor, again, tumors are commonly seen in certain parts of the heart, like myxomas in the left atrium, and nephromas in the right atrium, and maybe most common tumor probably being the papillary fibroelastoma, which are often seen at the tops of things like the aortic valve, just the tips of the leaflets. And don't forget the metastatic disease is always more common than primary cardiac disease. All right, well, thanks very much, guys. I think that's probably about all we've got time for, unless there are any other comments or questions.
If you'd come at this from a deep transgastric, would that perhaps have helped? Because then you would have removed perhaps the lineup that was causing the reverberation.
Yeah, if I'm trying to remember when I've had a deep gastric view where I'd feel confident about saying anything about the aortic root. I always sometimes find them quite tricky to get a beautiful view. I can often get the Doppler profile, but I sometimes find the actual sort of 2D morphology might be different. But if you're at that, maybe at 120 degrees at the, maybe if you're at 120 degrees, if I'd taken a decent, if I missed it out, yeah, I think I have by mistake here. You know, if I'd gone to 120 degrees here in the gastric view, I might have been able to pick that up. So absolutely, it goes along with the lines of looking at it in multiple different views, as Louise was saying, and seeing if the lesion is still there. And it goes with that rule in focused echo I keep saying, is if you've got an abnormality in one plane, you've got to back it up in another. Yeah, nice comment, Jamal. Thank you. All right, guys, thanks very much indeed. See you next week, okay?
Cheers.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.